Heidi, hello everybody, good morning. Happy to welcome you to Northern Doctors Day of 2021. Unfortunately, because of the COVID ongoing situation, we've had to yet again meet virtually, but hopefully everybody will have a good day and get some learning. And hopefully for 2022, we'll be back onto regular scheduled programming in person. Before we get started today, I'd just like to acknowledge that I'm speaking to you from Prince George, which is on the unceded and ancestral lands of the Kwale people. I know people are coming to us this morning from various parts of northern British Columbia and even as far north as Inuvik, and would appreciate if just everybody would take a moment just to acknowledge the territory that they are coming to us from today. So just as some kind of additional acknowledgement, the program for today has basically been selected and organized by the Prince George Local CME Committee, which is comprised of the people that you see here on this slide. I do want to give a bit of a shout out to Jaylene Emery, who without, as well as with Ashley Reisman, we would not have a Northern Doctors Day in terms of a lot of the logistics of trying to set up and organize speakers. And I can kind of speak to myself if I'm a fairly typical disorganized physician, and without their support to get things going for today, it may not have come to fruition. For those who do not know me, my name is Melissa Diamond. I'm an emergency physician here at UHMBC in Prince George, and I'm the chair of the CME committee, and I took over from Dr. Ian Skocking, who had been in this position for, I think it was something like 20 years prior to taking over. So some big boots to fill, but hopefully with what we've been able to put together, everybody's able to take something away. And I'd like to welcome Darlene McIntosh for an opening prayer this morning. Darlene is an elder who comes to you from the unceded ancestral territory of the Kwale Nation. She's also a cultural advisor with the Aboriginal Resource Center with the College of New Caledonia. So Darlene, I'd like to hand over the reins to you and welcome you joining us, and thank you for joining us this morning.
Thank you, Hadi and Bandada Hunsu, which is a carrier word that says good morning. It's my honor and pleasure to be able to come and give an opening welcome to the 45th Annual Northern Doctors Day. So I guess it looks like you've got a lot of work ahead of you. It is a Friday, it's the end of our week, and I'm sure like the whole group is probably exhausted after a full week of work and multitasking and so many things happening in this world. So the first thing I want you to do is take a nice deep cleansing breath throughout your whole body. Nice deep cleansing breath. A lot of times we forget about our breath and what it does for us. Very important. If I covered your nose and mouth, you would sure be taking my hand off your nose and mouth really quick. So it's the unconscious breath that we just continuously do. It's the first gift from Creator. The day we were born, we took our first breath, and we don't stop breathing for 70 or 80 years. And what do you call that? I think it's a miracle. But we need to be conscious of our breath as we pull it into our body and feel it coming in. And does it go throughout your whole body? Are you feeling that? Or does it just land in your chest area and you can't pull it down any further? So what you need to do is really consciously take a look at the breath, work with your breath, and we realize that not only does it give us life, but it also calms our nervous system down. So in saying that, I want you to maybe just close your eyes just for a moment in time, just for this moment. And I want you to find yourself outside. This morning in Prince George, of course, it's cool. We're in winter. But when we stand, we're facing the east direction. And we know that every day the sun comes up in the east direction. So we see it come up. Even if we have a cloudy day or a rainy day, we know that that sun is coming up. So as we honor and we are in gratitude for that direction, as it brings us a new day, a new beginning, and new possibilities. And this we are grateful for. Every morning we have a clean slate to make a decision on how our day is going to unfold. So we want to start it off in a good way. So as we feel that little bit of breeze on our face, might be cool, or maybe you're feeling the sun come up and you're feeling the heat on your face. And you take a look around and you honor the place that you work and play on. And then you take that breath all the way down into your feet. You feel your feet sink into the deep, rich soil of Mother Earth. You can smell the richness of her soil. You can feel it between your toes. And there she grounds you into today, into this very moment. So just imagine yourself, all 32 of you who are participating in today's virtual platform. But imagine yourself outside in this huge circle. And you feel the person next to you, can feel their arm or shoulders connecting with yours. And then that energy starts to connect with each individual, all 32 of you, so that all your energies are connected. And then you become one. You're able to collaborate, you're able to share, you're able to have understanding, you have clarity of thought, and you come together to create whatever it is that you want to do in this event that you're having today. So we come back to ourselves in a good way. We're energizing our body, we're oxygenizing our body, and ready to commit to a day's work. So this morning we ask Creator, or whoever the idea of who the greater being is, which has many names, but I use Creator. We call on Creator, the grandfathers and the grandmothers, and all of our ancestors. No matter where you come from, all of our ancestors, come be with us today. Surround us with the energies of our ancestors. Let us hear you in the songs of healing. So we're asking Creator to be with us. Thank you for this beautiful day on Mother Earth. Thank you for the gift of community. Thank you for bringing all who are present, ready and willing to work towards building a strong relationship and having passion for the Indigenous ways of being that has supported our people on their journey of life for eons. And most important, willing to make a powerful commitment to self and those around us. May we express healing through who we are, feeling the vibration of all that has passed through your doors. Mother Earth, as we stand on you softly, connecting with your heartbeat, thank you for continuing to support us, allowing your essence to vibrate through us, interconnecting with all that lives in and on your body. Creator, Great Spirit, hear our prayers. May all those present journey in the healing, light, and unconditional love. May your choices be freeing, and with each step growing in spirit. Know that Creator walks with you, feeling and experiencing life through you. May you walk softly on Mother Earth, leaving no footprints. Creator, hear our prayers. Creator, hear our prayers. All my relations, Masi Snachelia. Thank you.
You see, Darlene, thank you so much for that kind of welcome into our day. Perfect. So just a little bit of a roadmap for this morning, which we've already entered. We're going to have 2 sessions back to back that will take us till about 10:30, where we will have a coffee break. My goal for today is to try and keep on time, just out of respect for our speakers who are joining us, as well as for everybody. I think, throughout the day, I know people are going to be likely needing to come and go due to their various commitments. So if you do need to go and come back, we allow you and welcome you back. And if you're more comfortable having your camera on or off, it's up to your choice. I know some people are coming to us from areas where the bandwidth isn't that great. So if that is your preference, we're happy to have you join us today. And with that, I'd like to say Heidi and welcome to Harmony Johnson, who's going to be talking to us about cultural safety and focusing on kind of the considerations and learnings that we should, as physicians and nurse practitioners and other practitioners in our communities, take out of the In Plain Sight review that came out probably about, I guess it's getting close to about 18 months ago. And we really thank you, Harmony, for joining us this morning. I know we've never met, and this is kind of our first virtual meeting, but we appreciate you joining us up here in Northern Health. And with that, I will hand over the reins to you, and we'll go from there.
Thank you. Ikajikwi, good morning. My name is Harmony. My ancestral name is Sidlakis. I'm joining this morning from lands owned by the Tsleil-Waututh people in North Vancouver. I want to start by thanking Elder Darlene for that lovely opening. I have a really high stakes week this week. I was saying to a friend of mine last night, every day is just something big. So I really appreciated that grounding for the group and for me in particular. I needed it. So I am going to talk through a set of slides on the In Plain Sight report. The 1-year anniversary of the release of that report is coming up on Tuesday, November 30th. So we are preparing a set of observations about that. Mary Ellen Turpelafon, who ran the review, and myself, who, like I said, I was the executive director of the review. She was the independent reviewer. So I've been thinking a lot about what's taken place over the last year and what hasn't. So I'm going to talk through some of those things with my time with you this morning. So I am going to try to share my slides without humiliating myself. I'm hoping someone will tell me if they can see something they shouldn't be seeing. Do you folks great cover slide? Okay.
Yeah, it looks great.
Nodding and smiling. So, okay, that's what I'm looking for. The artwork for the report was done by a young gentleman by the name of Elliot Whitehill from Snuneymuxw Nation. He developed 4 original pieces for us. So I'd just like to give him a shout out before I get started. So just some context. So I'm going to talk about some difficult things. I'm going to use some words that sometimes we don't hear some of those words every day, and we haven't quite built up the stamina around talking about these issues fully. So for Indigenous folks, some of the things I'm going to be talking about are definitely challenging. It's challenging for me to talk about. It's emotional labor for all of us. So would just say it's not going to hurt my feelings if people need to jump off. And that there are supports available for Indigenous people through things like the CUA's Crisis Line and the National Residential Schools line. For non-Indigenous folks, this type of work is work about learning new things, but it's also about unlearning things that we think we know, or we're not actually sometimes admitting to ourselves that we have been socialized in. And so this is as much about unlearning those things as it is about learning things. And like, I do a lot of work in this space. I teach on issues of race and colonialism. I write on this stuff. My regular day job, half-time, is the VP for Indigenous Wellness and Reconciliation at Providence. So these are things I spend, most of my life on. And so I observe kind of what happens in these conversations. And I observe that some of these conversations can trigger really common feelings. Those are things like discomfort, for sure, sometimes resistance, shame, guilt are really common, sadness. So I just want to acknowledge that that's common and that's okay and that's normal, and we should accept those things. We shouldn't resist them, shove them aside. We should sit with those, and we should attempt to push through those feelings. Feelings of guilt in and of themselves don't help us tackle the problem. They don't serve us as Indigenous people, but they are a typical part of the process, and they can be transitioned into feelings and a sense of responsibility. So that's my plea to everyone, is if you're experiencing those things, remember that it's typical, try to turn it into a sense of action and responsibility. So this review we were asked to do by Minister Adrian Dix in, I want to say, June of 2020. The review had a fairly broad scope to examine the context of Indigenous-specific racism in the healthcare system in British Columbia. We had, I would say, full cooperation and support from pretty much everybody in the healthcare system: CEOs, unions, regulatory bodies, physician leaders, nurse practitioner leaders, nursing leadership, Indigenous peoples and organizations. So it was the subject matter is challenging, but we did have, I think, a good environment to have the right conversations for the review. We didn't have to kind of push too much on people. We also had delegation from the minister as it related to the data that we needed to pull for the review. And that was really the transformative aspect of this review, was having the ability to compel the data that was needed and the political will to examine it. So this slide represents the methodology that we undertook for the review. On the left-hand side, all those teeny tiny dots, we directly interfaced in our work with close to 9,000 individuals. The majority of that was through two major surveys that we ran. One was intended to hear from Indigenous peoples on their experience in healthcare. We had close to 3,000 respondents for that survey, and they weren't just Indigenous people, but non-Indigenous people. So we kind of had a comparator population within. Health workers survey, we had close to 5,500 respondents to that. Then we had an open email and telephone line, and through that, we had about 600 respondents by the time we did cutoff for data analysis purposes. By the time we handed this over to the ombudsperson to steward this phone line, there was, I think, I want to say 900. And then key informant interviews, we did 150 approximately of those. Then on the right-hand side, what you see is the data analysis that we conducted. So we did data matching between kind of client registries for First Nations and Métis individuals with major health system data sets, like the Health Systems Matrix. So through doing so, we were able to examine the health utilization and outcome data for 185,000 Indigenous peoples in BC. We also pulled data from surveys through which Indigenous people are either self-identify or the target population. So that includes people are familiar with PREMS and PROMs. There was that big COVID Speak survey that they've run a couple of times. And the Regional Health Survey, which is a survey conducted in First Nations communities every 5 years. For the first time, we also pulled complaint files from Indigenous peoples from the 4 largest regulatory colleges, the First Nations Health Authority, and patient care quality offices across the health authorities. And we did a literature review. So this is the data pull that we did for the review. So one of the almost like meta findings, I would say, of the review was around the use of words and terminology. And so I teach in this space, and I remember the first year I was like teaching this group of master's students in my class, and you know, I'm like jumping in talking about all of these like concepts, and then like I had a student be like, could you talk a little bit about like what does Indigenous mean? And it was like a real reminder to me to like back up and check your assumptions about whether you're even kind of talking the same language. So we took that a little bit into this review of like probing on, like we're using the same words, but do they are we carrying the same meaning behind these words? And like I said at the beginning, I think that we're not really used to using these terms very much. And so some of these words are also about unlearning as well as learning. So what this slide does is attempt to kind of like level set a little bit about some of the terms that we used in the review that I'm going to be using as I speak with you this morning, and separate them out a little bit so they're not just a list of definitions, but it's understanding the relationship between these terms. So on the left-hand side, these are like the kind of problems that we're dealing with. So racism, right? Like we tend to kind of, I'm using we in this really broad sense. Generally speaking, a lot of folks, when we hear the word racism, we tend to think of like an act that's like committed, right? That it's like a deed that's done against somebody else, like between two people. And yeah, like for sure that there can be an act of racism. But what we're talking about here is really that race and racism is a social process, that we're all socialized in this concept of race, which kind of creates a hierarchy of value of human beings on the basis of things like skin color and sometimes identity in the case of Indigenous people. So racism, social process, we're all socialized in it, kind of creates a hierarchy of value, white people at the top of that kind of hierarchy. Indigenous-specific racism, I'm going to talk a little bit about the unique forms of racism about Indigenous peoples on a future slide. And racism can be interpersonal. Like I said, it can be an act committed against somebody. It can also be systemic and in our institutions and policies. Prejudice, this is prejudice, profiling, discrimination, all these kind of terms kind of go together, right? So if race is the socialization, what happens when we're socialized in the concept of race? Well, we kind of have a picture of someone in our heads, right? So we kind of like put that on them when we see them, and that's profiling. So, you know, we see, you know, someone who say is Indigenous, we might kind of profile them a certain way. It's a preset set of beliefs. And that leads to kind of prejudicial or discriminatory kind of thoughts, treatment, actions by individuals or by systems, whether we acknowledge those at the front of our minds or whether it's this kind of like implicit association and socialization, kind of more in the back of our minds. And privilege is the ability not to experience that, to not have to think about it all the time, to not have to go out and talk about it all the time. Someone like me who's Indigenous, I experience certain forms of racism as a result of my legal status, and what that meant for my socioeconomic status when I was growing up, some of the policies that I've experienced in my life. But I also know that I'm a white passing person. And so that's privilege that I carry, that I can choose in the moment. Most people don't profile me as Indigenous. I don't necessarily experience interpersonal racism walking about in my day-to-day as some of my relatives do. I can choose when I'm asked, do you self-identify as Indigenous? I can look around and be like, did I feel safe to self-identify as Indigenous? Maybe, maybe not. And that's privilege. And so you can see on the slide, there's a quote from this dad from the North who's married to a First Nations woman. clearly said, like, I take the kids to all the medical appointments now because me and the kids get better treatment because I'm white. And that's privilege. So that's kind of the set of issues we're examining. Now, when we look at what are we looking for? What are we looking to achieve to combat those problems? There's kind of two mindsets. One is an anti-racist mindset or approach. Anti-racism makes us kind of feel good, right? Like it's like an active term. I don't know if people are familiar with Ibram Kendi's work. I would highly recommend it if people haven't read it. His proposition, of course, is that there is no such thing as not racist. You're either racist or you're anti-racist is kind of his frame. And so by kind of saying, well, I take on this approach of being anti-racist, meaning I don't tolerate racism in any form. And part of my responsibility as a human being is to speak up and to work against racism when I see it. So that can make us feel good. It can make us feel like we are empowered, that we're doing something. And that's a good thing. And we like that. And at the same time, for me, and this isn't like, I don't know if anybody else shares this view, but my view is that approach of anti-racism goes hand in hand nicely with this concept of cultural humility, which is more of an inward-facing, personal, reflective practice. And to me, it kind of tempers the anti-racism piece in a good way, because it's also really easy to slip into savior mode and like, I'm anti-racist, I know the answers, I'm going to save everything. Like we like the energy, but we also want that tempered by self-reflection. How am I socialized in this concept of race? How am I showing up? What do I have to unlearn? What do I have to learn? Those are some of the qualities. Do I know? Am I making assumptions that I think I understand and maybe I don't? Those are the types of qualities emblematic of cultural humility. And I've got a set of questions at the end, just as a leave behind for all of you, that can be part of your cultural humility practice. So to me, those are the two things that kind of go hand in hand: anti-racism, cultural humility, the mindsets we're looking for. And why I'm belaboring this in some ways is that and I've been involved in this, like, I've been around in healthcare for a long time, most of my career. I have been deeply involved in the work around cultural safety and humility. And what this review was like, hit me like a lightning bolt, is like the terms cultural safety and humility, I think, are like, they become a motto or a slogan. And people are using those terms, cultural safety and humility, cultural safety and humility. And then we would be like, yeah, but like, okay, that's great that you have that commitment to cultural safety and humility. What does that mean? What does it look like? And then it kind of like fell apart. So I'm belaboring this because I want us to kind of like think about words and what they mean and make sure that they have meaning to us. Because all of that work is intended to achieve a set of desired outcomes. So Mary Ellen and myself, we both do a lot of work together and respectively on issues of Indigenous human rights. And Mary Ellen in particular, has done a lot of good work on the Declaration on the Rights of Indigenous Peoples Act in British Columbia, and now the piece of federal legislation achieving the similar ends. So because this is law in British Columbia, that we affirm the UN Declaration, we use that and it has been named by the TRC as the framework for reconciliation. We really, really used the UN Declaration as the frame for our analysis and our recommendations. And so when we look at what are Indigenous human rights to health in the UN Declaration, they are the right to use and practice our ancestral teachings, medicine, science, ways of being healthy. They are the right to substantive equality. It's the right to experience and access healthcare without discrimination, and it's the right to self-determination and decision-making. So those are kind of the four main buckets that I think about in the context of Indigenous human rights to health. And so those are the outcomes that we're striving for. Okay, so in terms of what we found, like I said, we ran a bunch of surveys. 84% of Indigenous respondents indicated that they had been on the receiving end of some form of discrimination, racism, and health. Over half of Indigenous healthcare workers reported experiencing racial prejudice at work. And this vast majority of this from colleagues or people in supervisory positions to them. More than a third of non-Indigenous healthcare workers had witnessed racism or discrimination directed at Indigenous patients. That number was, I think, doubled for Indigenous folks, which is unsurprising. Like, I think we're more attuned to it and pay attention. 13% of healthcare workers made racist comments in the survey. And that's on the slide for a couple of reasons. Like, one is yeah, that's like a significant number. It's not surprising. I tell you that 13% is, like, when I think about all the emails we got, you know, all the other spam that Mary Ellen and I got through the course of the review, that we got after the review, that I still get to my emails and stuff. You know, it's not surprising. It kind of comes with the work. And those are the more egregious things that I'm sure you're all thinking of. But we did do an analysis of the racist comments in the survey to be like, what is this actually telling us? There are some that were like the fringy stuff, for sure. But there was a lot of this that, to me, spoke to issues of what holds racism in place. And there were two things there that I thought were important. One was workplace solidarity. And two was the ability to kind of recognize racism in someone else, but not recognize it in one's own belief system. So there were comments, lots of them. Things like, yeah, I saw a woman called, Indigenous woman called a slur in emergency, but, you know, we're really busy in Emerge and they're always here frequent flyers. What do you expect? Or what do you expect? They just have too many kids with too many different dads. So I think that those are just a couple of examples. Like, the themes are what's important here, right? People trying to kind of explain away and kind of keep that workplace, you know, we have to tell ourselves stories to get through the day. And I think there was a lot of that in those racist comments. In terms of why racism persists from the perspective of the people contributing to the survey, healthcare workers in particular, employees not willing to speak up was huge, lack of speak up culture, perceived lack of accountability by leadership to stop discriminatory behavior when it's happening, and insufficient numbers of Indigenous healthcare professionals. And this is the inherent kind of like paradox in this work, right? Is, well, if having more people like Indigenous healthcare professionals like me, like the team that I supervise in healthcare is part of the solution, but over half of us are experiencing racism at work, like there's a problem there that we have to fix if the solution is actually going to yield any dividends. We also asked people, okay, well, how do we solve this problem then? What was encouraging about these responses is that there was many of the same priorities for change from both Indigenous patients and from all the healthcare workers. So like real high agreement, like we need better policies, we need more training, we need more Indigenous healthcare workers, like agree. The difference between the two, unsurprisingly, Indigenous patients saying, I don't feel safe to complain or to provide feedback, like needs to be more meaningful. And healthcare workers, again, just saying we need clearer permission from leadership to promote cultural safety. This infographic was kind of the centerpiece of the review. People kind of tend to recognize this more than other things. In some ways, it's the review at a glance. So if I start at the well, I guess it's like the 11 o'clock, like our people were well here since time began in these territories. We have our own medical systems, our own science, our own philosophies of health and well-being, our own practices that kept us well. These are diverse across our nations, but also united in many ways in this philosophy of one's health and well-being is shaped by many factors: relationship with land, relationship with self, relationship with community, with values, with our ancestors, with our future generations. And colonialism like, so kind of moving towards kind of the middle. Colonialism is a system of oppression, subjugation intended to kind of wipe people out and assume their resources. So how, like, I get asked this a lot, especially since May, when the discovery of children's bodies buried on the recovery of children's bodies from residential school sites. I get asked this a lot, like, how did we not know about this stuff? And like, I don't know how to explain that, because like I knew and my family knew. But I tend to draw that back to like there's these beliefs that were cultivated about Indigenous peoples that enable those policies like residential schools, Indian hospitals, Indian Act, the pass system, all of these things were enabled, like they were an accepted part of society for a long time. And it's really only kind of recently that people are like, oh, actually, that is unacceptable after all. But those are beliefs, like they were founded on the fact that there were beliefs created about Indigenous people. So things like they're dying off, they're inferior to us, their culture is strange, they're dirty, they're contagious, they're bad parents. So those are all beliefs that were cultivated about primarily First Nations people in British Columbia that then allows for these oppressive policies. So people are bad parents, well, we should take their kids away. Oh, they're contagious, let's put them over there on that reserve. They're dying off, well, we'll create these separate hospitals for them. And these are the underpinnings within society. It's our socialization in these beliefs. And our institutions are built on those beliefs in many ways. We still deal with many of those policies today. And those stereotypes, those beliefs, have lineage into today. So if we're moving over towards the 2 o'clock, we did extensive analysis of all that stuff I talked about on that methodology slide. These are the common stereotypes about Indigenous people in healthcare today. Less worthy, drinkers, alcoholics, drug seeking, bad parents, frequent flyers, non-compliant, can't follow instructions, less capable. This huge one, get stuff for free. Then there's this whole layering of misogyny about Indigenous women, that we're more sexually available, we have too many kids, we have a higher pain tolerance. So these are all these kind of stereotypes that we saw in analyzing all the data. These are not specific to healthcare, I'm telling you. There's a lot of these that exist in other sectors. There's a report from the Auditor General in 2015 about First Nations education, about the racism of low expectations of Indigenous kids, for example. So less capable is a very pernicious one. So these stereotypes, what do they mean? How do they shape experience? Well, they do shape discriminatory care. Yes, there's some abusive interactions, denial of service, kind of less effort, ignoring and shunning. If you think someone's less capable, you might put less effort communicating. Inappropriate pain management, you think somebody's drug seeking, prescribing patterns different. Medical mistakes. So think somebody's kind of intoxicated, then maybe you're missing a diagnosis, and disdain for cultural healing. And then I'll ask you to imagine in your mind that there's a kind of dotted line across the circle from discrimination to poor outcomes, because we were also able to, through the regional health survey data, run a bunch of crosstabs that showed us that the very experience of racism has a direct association, has an association with poorer outcomes. So higher rates of stress, distress, self-reported problematic substance use, for example. It also shapes access and utilization patterns. So some of this is systemic, like policy stuff, right? So we have lots of geographic barriers for Indigenous folks because people were pushed to the fringes of their territory onto these small reserves, and they're still kind of underserved And I know this is something that I don't need to preach to you all about. If the environment is kind of chilling to you, you kind of avoid it at all costs. There's lots of mistrust and avoidance of care that was reported to us. Lower GP and NP attachment. And all of this, and not only this, like for sure, there's a bunch of other sectors feeding in here that kind of contribute to poor outcomes. But health in some ways is like this endpoint system, right? We like reap the failure of all these other systems. And so what we see here is disproportionate and inequitable outcomes. Higher, like I said, suicidation, stress, distress, reduced life expectancy, increased rates and faster progression of chronic disease, infant mortality, etc. And often those outcomes in the past have just been reported on their own, right? Like study released showing whatever, First Nations kids die at higher rates. And without this context of really attributing what is the root cause of that disparity, that just feeds that stereotype. So this cycle goes round and round, right? Like, oh, yeah, higher rates of infant mortality. Well, what do you expect? They're bad parents. So this stuff can just feed itself if we don't kind of diagnose the problem and intervene. So this is the summary of the findings. I like to bucket them into two, right? Like where there's like findings and then we examined the solutions in place. So I talked about a lot of this already on the last slide. I'll just note that women and girls in that circle are like disproportionately impacted. I'll talk a little bit more about that with respect to the data report we released. Public health emergencies kind of magnify this issue in a couple of ways. One, like I can use my own community as an example. We had a COVID outbreak. It was like immediately bus service is suspended to the community. Our people are like shouted at in the grocery store. And this is like a community that's like this beacon of like municipal First Nations relations. And it was like pretty quick that stuff like got swept away. So there was this interpersonal kind of racism that occurred immediately. And it didn't happen when there was like an outbreak in the, suburb 10 minutes down the road. And we also saw a disproportionate impact of both COVID and the public toxic drug supply emergency in terms of outcomes for Indigenous folks. In terms of solutions, there's lots of excellent work going on in the system on this issue. It's not like nobody's like not doing something. There's lots of good work. It tends to be not systemic work, like really underpinned in the system. It tends not to necessarily be really focused on kind of point of care experience. There's a lot of work that's driven by kind of like passionate leaders in different places, and it's great, but it doesn't in the aggregate necessarily have the impact that we need. So education and training programs are not, like there's lots of barriers. There's not basic gateway training. In 2006, I was the kind of policy lead for BC First Nations writing the Transformative Change Accord First Nations Health Plan. And I remember I was like 20, whatever. And I'm like writing this plan, really early in my career. And I remember writing, like we were going to have mandatory cultural competency, it was called at the time, training for all healthcare workers. And then here I am, like way later in my career, again, being like, no mandatory training for healthcare workers, like 15, 16 years later. Like we're not necessarily doing enough there. And it's not really focused on necessarily how people actually carry out their practice. There's a lot of like factual information about things, but then there's a gap between that and, well, what does it mean for me? Complaints processes, not super effective for Indigenous people. And there's really different reasons that Indigenous people don't use a complaints process than non-Indigenous. So we asked that question in the survey. Non-Indigenous folks were like, way too much paperwork. Indigenous people were like, they're not going to believe me. Nothing's going to happen. So again, this kind of mistrust issue as it relates to complaints. Indigenous health practices and knowledge not well integrated. There are, like I said, lots of good examples of where this is done really well in very local settings, but not necessarily kind of systemically enabled. And that led to our conclusion about insufficient hardwiring. Like we haven't pulled the deeper levers of change, policy, legislation, those kinds of things. Indigenous structures and roles in health decision-making and leadership need to be strengthened. That includes both kind of reframing, realigning some of the existing institutions like and processes for collaboration through groups like the FNHA and Métis Nation, but it also includes senior leadership from Indigenous peoples to change that system from the inside. And then accountability. So how are we measuring this? I mean, Mary Ellen and I received delegation under the Ministry of Health Act that enabled us to take a look at this issue. I hope this isn't just a one and done, but how does this create a bit of a baseline for us to examine this issue on a more routine basis? And on that note, we did produce a separate data report that was released in February of 2021. It's a fairly robust, like we released as much as we possibly could. And I would say there's like kind of three conclusions that I in particular took from that exercise. One was that Indigenous folks tend to receive services not on the primary and preventative side as much as towards the secondary and tertiary side. This is despite the fact that like there's a greater need for primary care and preventative services amongst Indigenous people. Emergency department, tends to be the locus for much of First Nations healthcare across all kind of age groups. And Indigenous women are just like shouldering the greatest burden of any population we looked at, like greater disparities, greater sense of mistrust, greater impact from the public health emergencies, leaving hospital against medical advice. So the report included 24 total recommendations. It took a really strong human rights approach, as I mentioned earlier, and a strong systems focus. Because like I said, there's kind of good pockets of work all over the place and excellent examples of leadership on this work. So systems, we had 10 total recommendations there. Behaviors, so how do organizations show up and where does the system need to kind of behave differently on certain priorities like women's health, mental health, and wellness. And then beliefs, so a set of recommendations kind of around training and education. Those are like the three main buckets. And then we had one on implementation. There's a few things I thought might be relevant to this group. One is like this need to kind of increase attachment. We know this system's like, there's issues with like, how do we define attachment and all of these things, but like this concept of like, let's shift the focus like to a different part of the system in terms of how Indigenous people are accessing care, greater integration with mental health and substance use, making space for Indigenous people to practice medicine and to feel safe talking about it. Like so many people are like telling us like, well, I do, but I never tell my doctor about it because I'm going to get judged. Speak up culture. So speak up against racism. How do we create that culture? And, so much of that really depends on leadership setting the tone and enhancing cultural safety at point of care. So again, this kind of self-reflection, understanding common biases, taking time, building trust in that therapeutic relationship. Maybe before I do that. So we're coming up on the 1-year anniversary. So I've been thinking a lot about what's changed over the last year. There are really positive things. All the health authorities and now have VPs for Indigenous health, and I think that's making a big difference. There are standards being developed by regulatory bodies and by the Health Standards Organization that describe what do we mean by cultural safety and create practical tools and resources. There were amendments introduced into the legislature last week to make Indigenous identity protected grounds under the BC Human Rights Code. These are major positive developments. And there are things that haven't changed. Like, I just wonder, like, has much changed kind of at that experience kind of point of care, which is partly my reason for joining Providence is, well, if I'm going to like talk about it, then, am I going to try to do something about it myself? So, that's part of the struggle and that's part of the work we're all involved in. I don't think that the work's been done on, using the Declaration on the Rights of Indigenous Peoples Act to really advance the change. I don't think much has happened on Speak Up culture. So Public Interest Disclosure Act application, that hasn't happened to health authorities yet. I think there's a long way to go on that front. So anyway, just a few kind of high level observations, and there'll be a lot more coming next week on that in a bit more of a written format from Mary Ellen. So in terms of like, what can we do about this issue? This is like stuff I just share with everyone. This is like human being stuff. It's not necessarily like directed at health professionals. Like, I think the most important thing people can do is educate themselves. I think we wait and we use as an excuse, and I use myself too, right? Like, we wait for some training program. And then that, in the meantime, we don't have to do anything. But there's tons of free education out there. There's like webinars, there's podcasts, there's books, there's free courses. The University of Alberta has a massive open online course on this. Like, start a little book club. Take that open online course with a cohort and talk about it. Like, I think to me, that is the single most important thing that people can do. Have discussions then with your circles of influence, participation in change efforts, community memorials, things like this new National Day for Truth and Reconciliation, which just kind of like happened really quick. And then we were all like, Indigenous people having to plan all this stuff about our own kind of trauma. Making space for Indigenous voices. So sometimes it's like, you're invited to speak at something. It's like, is there an Indigenous person that's speaking? Is it appropriate for me to do this? Like, sometimes that, like, using your privilege for good can be transformative. Speaking up against racism, direct your dollar towards Indigenous businesses, being a good colleague to Indigenous people. So I think a lot about this concept of cultural loading. People like me, like, I do this work, I get paid for it, I choose to do it. Many of my colleagues don't, right? They're just like Indigenous person, like RN, like working their shift. And then they're asked kind of out of nowhere all these like kind of potentially triggering or traumatizing questions. So I just would encourage people to take some care, like build real friendships and relationships with people and self-educate as much as you can before kind of asking or like randomly asking friends. Like, when the news kind of broke around Kamloops, like, I had some folks knocking on the door of our team's office asking if we could organize ceremonies for people. And I was like, why? Like, no, like, we're here to see patients. We're here to deal with the Indigenous patients in the hospital. Like, I appreciate that you have your feelings of stress and distress, but it's not necessarily up to our team to help you process those. So just kind of be very thoughtful about that. And then maintaining hope is the big thing, right? Like, all of this, like, I'm talking fast. I'm like talking about all these damaging things. It's like challenging. It can be overwhelming. It can feel almost like climate change, right? Like, it's so big. What can I do? Well, you can do things. These are all the things you can do. Like, please don't let me like crush any hope. I have hope. And then in terms of like personal reflection stuff, like, this is some of the stuff that I think is helpful for people to just reflect on in their cultural humility practice. I've adapted these quite a bit from a book called Me and White Supremacy, and I didn't talk about white supremacy notice in this talk. But I would encourage you to get that book. It's like a really easy read. It's like 2 hours, and it's just very, very practical. So things like, how do you see your role and responsibility in disrupting racism? Like, are you prepared to show up differently? How? How does your fear maybe get in the way of you intervening or asking others to do better? How would you respond to seeing something in action? And this one's really hard. And I really believe, like I know it sounds like kind of cheesy or whatever, but like, I believe you need to like kind of envision yourself in certain scenarios to build up stamina to be able to intervene in the moment. Like, I've been in lots of situations where I've been really like uncomfortable with something that's like I'm observing or happening over there. And like my heart rate gets like elevated and I feel really uncomfortable and I'm like kind of frozen in the moment. Like, should I say something? Should I not? So like, I think it helps to like try to imagine yourself in certain situations so that when it does happen, you have kind of thought that through. What efforts have you made to invite others? What are like 3 things you're going to do? And, you know, in leadership, how do you plan to hold yourself accountable? So those are a few questions, just a few, like there's lots of that book and lots of other books that can give us some of these prompts and tools. These are just a couple of sites. So the kind of summary report, long report, data report, and then we did a little thing on the UN Declaration and its relationship within plain sight. So those are all up on, we kind of have this like legacy site for the review. We did write a little piece for BCMJ some time ago. That we also wrote a little piece for BC Studies. I wrote a thing for Healthcare Quarterly last month on this issue of Indigenous leadership and cultural loading. And then next week will be the 1-year anniversary. So I think there'll be quite a bit of stuff kind of floating around on this kind of like important opportunity next week to reflect. So that's it for me. I know I talk fast and I talk a lot, but I hope that was helpful for the group.
Thanks so much, Harmony, for that. That was really helpful to gain some better understanding, at least for me, in terms of the process, and I really appreciate the recommendations. I'm just wondering, does anybody have any questions for Harmony, whether you want to type them in the chat box or ask over audio? Hi, Colleen. I see your hand up.
Thank you, Harmony. That was amazing. I sent you a message privately with my question, but I'm going to ask it in front of the group. Could you define, please, and speak to where paternalism fits into colonialism? I, as a person of privilege, certainly experienced both, and I just am wondering how it plays into the report that you did.
Sorry, Harmony, you're just on mute.
That's a good question. It's partly why I do these is like people ask me something and I'm like, oh yeah, like good point. So I think, and this is just kind of off the top of my head, and now you've got me thinking about this, so I'll probably spend some time actually being more thoughtful about that later today. You know, essentially colonialism engenders this kind of, these set of like racist beliefs, right? And one of those is this one of like less capable. And so I think that really does tie with this concept of paternalism, right? Like we know better, like they can't take care of themselves the way that we could take care of them or not take care of them, right? Like they're less worthy, less capable. Therefore, we need to X, Y, Z. So I think that those concepts really are like paternalism in some ways is like the approach that's applied as a result of the stereotyping. And the stereotyping is there because of colonialism. Like racism just greases the skids of colonialism, right? Like that's its purpose. And so for me, paternalism is kind of part of that. And there is like all these intersections, which I prefer to kind of think about as kind of more like compounding oppression that's experienced particularly by, like I would say, like what we saw for Indigenous women, for example, right? It's like extra paternalism and like all this misogyny on top of that. So I don't know, I think I'm just rambling now, but I would say that I do think paternalism and colonialism are definitely hand in hand, and a paternalistic approach is kind of like the thing that gets outputted on the other end of the stereotype that Indigenous people are less capable. And that stereotype is the one that is like super pernicious and it's subtle. And I think a lot of us don't totally realize that we carry it around. Like I get it a lot. Like people know that you're the Indigenous rep to something. And then you show up and you like start working with people on something. And like, I don't know how many times I've been told like, oh, like really surprised. Like people are like, oh man, like you're actually really smart. Like, okay, like, thanks. Like, why would you say that to somebody else? Or is that just because you had a preset belief about me as being the Indigenous rep, right? Or, oh, you're really smart. You know, you don't have to just do First Nation stuff. I'm like, yeah, I know. That's like a choice I've made in my life. Like, so like, I think that one's like less overt, but it's really widespread.
Hi, Tracy. I see your hand up.
So I'm Tracy Morton. I'm a physician out in Haida Gwaii, and First Nations issues are pretty front and center out here because of the strength of the Haida Nation. And so I really wanted to just say hawa, or thank you for this amazing presentation. And I guess for me, being a physician out here for a couple of decades, there's been a lot of reflection on my connection to place, and certainly some of these stereotypes that I don't think I want to acknowledge, or, you know, I grew up in a very, frankly, overtly racist part of Northern Alberta, a lot of cultural tensions and so on. So just being here for such a long time, I think the In Plain Sight report, I read it right when it first came out and have gone through several iterative kind of responses to it. First was just frank disbelief that this could actually happen in a system in which I feel shouldn't be, or should be fairly, you know, kind of alive to these issues. And frankly, like, it came as a complete shock initially. And now, after, you know, kind of reviewing it several times and some other work, sort of Haida Gwaii work that I'm involved with, it's now, okay, how do we move forward? And for me, I think the biggest takeaway is to just acknowledge my privilege. And what that does is, like, it's pretty, you cannot argue that I'm privileged, you know, the role that I have. And it's also pretty hard to deny that my race has engendered a bunch of privilege. So from that, I can take where to go from this. Number one is gratitude. You know, I live in Canada. I'm privileged to live in Canada, privileged to have had my upbringing, privileged to have not have those racial issues front and center, like you've mentioned. Like, you know, I can see how you would feel, like you recognize with some of the comments that you just said about you being a group, and people will have had, whether you've known it or not, or whether they've known it or not, there's been biases that were attached to you, that, you know, you truly are smart and worthwhile and meaningful, and you could do anything you want. You don't have to be doing just Indigenous work. So I think that's quite remarkable that you know, people are still to this day, you know, evincing those kind of biases that they have, and, you know, quite unconscious. And it's only when you have these kind of conversations that come forward. So I just wanted to mainly say thank you. As a site, you know, kind of building on our idea of privilege, we're, like, next week, from a week from today, we're doing a cultural competency in maternity services. Whole afternoon, we booked off time. So we all kind of take In Plain Sight pretty seriously here, and we're kind of giving very careful thought to how to do good work and make things right and be more sensitive. And yeah, so just know that there's a lot of people doing a lot of personal work, and systemically and organizationally, you know, we at least are really trying to do our part. I can imagine a day that any new hire in Northern Health does a locally developed cultural competency orientation, which would be incredible, where you've got local content developed by the nation in partnership with the organization. Because, you know, if it's done well up front, it's going to avoid a ton of this, you know, this whole cycle that you put down, with the end result being poor care. Like, I think that is a very lovely diagram that shows, you know, we know the data shows that First Nations are disproportionately affected with poor determinants of health as well as health outcomes. And you can kind of work backwards and go, well, how do we move the clock in the other direction, so to speak? So anyways, this is mostly a ramble. My biggest thing to impart to you is gratitude, and carry on. It's making a difference.
Thanks so much. I took a lot from that. Yeah, I think on the issue of privilege, like, what we what we don't often talk enough about is the relationship between privilege and oppression. Like there are two sides of the same coin, right? So privilege we carry comes at the cost of someone else's oppression. So if we can kind of like get our minds into that space, then I do think it changes things, right? Like we can then understand how other people are maybe feeling or showing up into a relationship based on the privilege or experience that they are carrying. And it gives us a sense of maybe responsibility. Well, if this is coming at someone else's cost, then how do I use this privilege to create greater equity? So, you know, I'm hoping that there continues to be kind of conversation about those things being very highly connected. I would love to hear more about your cultural competency in maternity. So if you want to like send me stuff, I would love to read it. That's an issue that I'm really spending some time on with my colleagues at Vancouver Coastal and PHSA, kind of in that downtown Vancouver Lower Mainland region. And yeah, I like the local context is so important in the North. And so I really admire the work on kind of those local relationships and local orientations. It's a tricky one for me, right? I'm like, you know, at St. Paul's, we see people from everywhere. And so we work a lot with the host nations, but it's hard we just see a very varied and very different population. And so it's something I'm really struggling with how to do that well. And I just see it works so well in areas in the North and makes me envious. So I hope you keep it up.